All right, welcome back. We are picking up with information management on page 135 in the text, chapter 4. We're not going to cover all of this section in detail because some of it is going to be a re-review, especially of ICD-10 and HCPCS and CPT and DRGs that we've talked about in the hospital-based and in the ambulatory. So we're going to hit the highlights here. So starting under information management. The information management system in a managed care organization is determined by the structure of the organization. If the managed care organization owns facilities that are part of the organization, the health information management system would be similar to the systems described in other chapters of this book. And so then again, we're going down into our coding and classification systems. So two basic coding and classification systems used to collect and manage data in managed care are your ICD diagnosis system and the HCPCS procedure system. And so again, we talked about ICD-10. This is where you're actually coding the diagnoses, and then your HCPCS and CPT is for your physician services and facility claims for non-inpatient services. All right, so we're going to move over under page 136 to the section where it says special uses of coded data. Managed care diagnosis codes have an additional use in Medicare Advantage plans as a component of a system for the adjusting premiums paid to health plans based on a patient's health status. Traditionally, Medicare adjusted its payments to health plans based on geographic and demographic factors associated with each enrollee. That could be age, gender, their Medicaid eligibility, and their institutional status. Adding a diagnosis-based risk adjustment factor had the effect on increasing payments to a health plan for enrollees with conditions representing higher risk for more costly services. Dropping down to that next paragraph. In 2004, CMS implemented a more comprehensive model that considered all sites of service, not just inpatient hospitalization, as well as other traditional risk adjustment factors such as age and sex. The new model uses selected diagnosis codes to place patients into groups known as hierarchical condition categories, or your HCCs. The numerical risk factor associated with each HCC is a component in determining the amount by which payment to the MCO is increased. And depending on the specific HCCs involved, if an enrollee falls into more than one HCC, additional risk may be calculated and the payment to the organization increased further. The risk adjustment factors are different for beneficiaries residing in the community and those in a long-term care institution. Dropping back down to your DRGs. Diagnosis-related groups were implemented in the early 1980s for use in describing inpatient services. The classification system groups inpatients who are medically related by diagnosis, treatment, and length of stay. Patients are grouped into major diagnostic categories, or your MDCs, and further subgrouped into a specific DRG, and only one DRG is assigned per stay. All right, moving over to page 138, UB04 revenue codes. Revenue codes are collected on all claims submitted on a UB04 claim form. Normally, these forms contain facility and service charges from hospitals, skilled nursing facilities, and home care agencies. Revenue codes define a specific type of accommodation, ancillary service, or billing calculation. They are 4-digit numbers grouped into categories of numbers having similar meaning. All right, moving on to information management, data and information flow. So data are collected differently depending on the structure of the MCO. Staff model and group model HMOs are able to collect encounter data on the patients they see in their clinics. All types of HMOs are able to collect referral data after a referral has been issued, and all types of MCOs are able to collect claims data from providers requesting payment. So let's talk about these three different kinds of data: encounter data, referral data, and claims data. An encounter is a professional contact between a patient and a provider during which services are delivered. Encounter data are collected at this time of service and reported in raw form rather than in the forms of claims data. A referral is an authorization to receive a specific health service from a specific health provider that will be paid for by the HMO. HMOs issue referrals before specialty care can be given. PPOs and managed indemnity plans do not issue referrals because patients are allowed to see other providers if they are willing to pay the additional cost. Referral data are collected at the time the referral is given by all organizations that issue referrals. And then claims data. Claims data are collected as a byproduct of the claim payment process. IPA model HMOs, PPOs, and managed indemnity plans can access service data in the form of claims data. For facilities such as hospitals, the data available are from the UB04 claim form. Data for physicians and similar providers are from their billing form, the CMS 1500. All right, moving over to 139 to talk about statistical data. All available data, including encounter, referral, and claims data, are combined and organized to provide useful management statistics. The two major ways by which statistics are divided in MCOs are by member and by contract. Per member per month, this is the frequency of services utilization, and the cost of procedures are evaluated and displayed by employer purchasing group, by provider or facility site, and by provider panel based on the number of members in the MCO for that month. And then your other kind is per contract per month. This is the frequency and cost are evaluated and displayed in the same way based on the total number of contracts the MCO has for a month. All right, and then moving on to our electronic information systems. We're going to cover several here. So we're going to talk about eligibility and enrollment first. Enrollment is the process of placing a person into the database of covered individuals of the MCO. Eligibility refers to whether the person is allowed to receive care under the MCO contract and the dates of coverage. The enrollment database is similar to the Master Patient Index found in healthcare facilities and includes dates of enrollment and disenrollment, demographic information, and the party responsible for paying the premium. Then you have your benefit levels. They may not be the same for all members of an MCO. Most managed care organizations sell a variety of insurance packages, some that allow more services than others, or that allow certain benefits at a higher payment level than others. Benefit levels must be tracked for each individual member because many members have dual insurance coverage or different benefit packages, even within the same family or contract. Then we have our registration and patient scheduling. Hospitals within an MCO require a patient registration system, and all service providers require some form of scheduling software to manage their healthcare environment. Then you have your authorization and referral management piece. Managed care organizations provide pre-authorization for admissions and procedures and issue referrals for care that cannot be provided by the PCP. This information must be maintained in the computer system and must be accessible to the PCP. Then you have utilization management and case management. Computer software should identify cases that are appropriate for case management through evaluation of encounter data, referral data, and claims data. This allows the utilization management staff to assist the PCP in managing the multiple resources needed to care for complicated cases properly. And then we have billing, claims, production. Staff model and group model HMOs require software to create claims for another primary insurer for patients with dual insurance coverage. In addition, this software should have the ability to post payments to these charges and maintain accounts receivable information for tracking purposes. And then our payment and claims processing. The claims processing software allows the MCO to pay claims for authorized services and should verify the eligibility enrollment files, benefit levels, and referral data before the payment is processed. Capitated visits should be recorded in the claims database even though no actual payment is processed. Without this capitated data, there's no information to manage the financial aspects of the MCO that are covered under capitation. And then we have our cost accounting. The cost accounting module of the information system should tie together the accounts payable portion of the business and the accounts receivable portion from premiums. In staff model HMOs, coordination of benefits income also must be tracked. COB income is received when the staff model HMO bills another primary insurer for services it provided in its clinics. And then we have our advanced systems. So one of our advanced systems is electronic health record. So the answer to collecting patient health information and having it available through the network of facilities is ultimately the electronic health record. Without the EHR, the MCO is still a combination of different facilities that try their best to achieve effective communication in real time. The HITECH Act, a component of the American Recovery and Reinvestment Act of 2009, was signed into law to provide incentives to physician practices and other healthcare organizations for the implementation of EHR systems. This law provided incentive payments to physicians and hospitals that demonstrate meaningful use of a qualified EHR. The law also provided an additional $20,000 to physicians who utilize an electronic prescribing system and the Physician Quality Reporting Index. And then we have executive decision making. Data from any or all of the information systems may be needed to determine where and when decisions are needed and to help in the decision-making process. All right, staying on page 141, going to move down and talk about data sets. Going to talk about HEDIS. The Healthcare Effectiveness Data and Information Set, also known as HEDIS, is a core set of performance measures for managed care plans. HEDIS was designed in 1991 by NCWA to help employers compare health plans, understand the value of what their healthcare premium is purchasing, and hold the health plan accountable for performance against these measures. HEDIS provides a consistent measure of key performance areas, such as effectiveness of care, access, availability of care, satisfaction with the experience of care, use of services, cost of care, and health plan stability. HEDIS contains more than 70 measures, such as the number of pregnant enrollees receiving prenatal care within the first trimester and childhood immunization status. Information about HEDIS measures is available at the NCWA website if you want to know more. And then you've got employer-specific data sets. Some national employers, such as IBM and Xerox, request data specifically about their enrollees, either using HEDIS indicators or by identifying their own issues for tracking. This information helps them to determine whether the health plans they are contracted with are providing cost-effective, quality service to their employees and their families. All right, moving over to page 142, talking about quality improvement. The accreditation associations, CMS, and many employer purchasing groups require an active quality improvement program within managed care organizations to ensure that care is delivered in a cost-effective manner with consistently appropriate outcomes. The components of a quality improvement program for managed care organizations are going to be detailed as follows. So we have an oversight committee using a comprehensive plan. So to ensure that the quality improvement is a continuous process, the MCOs utilize an oversight committee that is guided by a comprehensive quality plan. The quality plan is developed by the senior staff and approved by the board of directors at least annually. The Oversight Committee receives and reviews reports and projects requests from subcommittees within the organization. The committee structure is designed to provide a place for each area of the business to report its quality issues and findings. And then we have quality indicators. These are a quantitative measuring tool for monitoring and evaluating performance. These indicators are important to an MCO because it is difficult to manage what has not been measured. Quality in an MCO depends on operational indicators, medical indicators, and financial indicators. So for test, you need to be able to tell the difference between an operational, medical, and a financial indicator. And so we're going to go through this list here on pages 142 and 143. So the operational effectiveness indicators measure how well the MCO is performing in comparison to present goals. These also can include patient satisfaction goals about how well the customer or patient thinks the MCO is performing. And so some of these examples are, these are your operational indicators: telephone call turnaround time, percentage of telephone calls answered in less than 30 seconds, appointment availability for all service areas, percentage of rescheduled appointments for administrative reasons, pharmacy refill turnaround time,